Hi students, welcome to the online lecture for our immune and lymphatic system. This is kind of a big transition point right now, mid-semester. We're trying to go to remote learning, and that can be a bit tough for some of you who aren't very computer savvy. So I'm doing my best to make resources available to you guys so that you can stay on track. We'll keep learning, keep educating you. So things are still a little bit unknown, but for now I'm going to be recording some of our lectures so that we can keep facilitating learning about the immune and lymphatic system. So we'll get right into it. Last week we talked about the immune system. That was chapter 10 in your book. And we know that the immune and lymphatic system protect the body against microscopic threats to homeostasis. So basically what that's saying is the immune system is our protective system to help us fight off foreign antigens, bacteria, viruses, fungi, things like that. We talked last week about the inflammatory response. That is the first step in the immune response. We know that with inflammatory mediators such as bradykinins, histamine, complement, things like that, we know that that's helping the body to protect itself. It's sending a bunch of chemical messengers. Some of your immune system is going to be communicating with these inflammatory responses, and it's telling us to, hey, there's something foreign in your body, let's fight it, and let's get rid of it. And we know that sometimes with the inflammatory response, it's the body attacking itself. That's the body attacking itself. So those are important to keep in mind. We know that the B and T lymphocytes are major forces in fighting infection. We talked about the B lymphocytes. They mature in the bone marrow. They circulate within the blood, and then they circulate and they're looking inside the blood vessels. They're looking for foreign antigens, things that are foreign to the body. So T lymphocytes mature in the thymus. Thymus is right here. And then also T lymphocytes, they go into the tissue. They go within the cell to fight foreign antigens within the cell, whereas B lymphocytes is mainly in the blood vessels, in the blood. T lymphocytes in the tissue inside the cell. The body produces a humoral, also known as immediate, and cellular, which is a bit delayed. Humoral, when we talk about humors, we talk about the body fluids. Those kind of responses are right away, and we can remember that because when we give a medicine IV intravenously, it works right away. Whereas when we give a pill, it has to go through the stomach and then get absorbed through the intestinal tract. Whereas the cellular is a delayed response to antigens. So we talked about humoral, which is immediate. That is typically your B lymphocytes. Cellular, which is a delayed immune response to antigen. That usually deals with the T lymphocytes that go into the tissues. So we know chronic substance abuse, in particular nicotine, alcohol, illegal drugs can alter the body's ability to launch an immune response. So that's important. Now we wonder why, people with chronic substance abuse problems, why are they always sick? Well, their immune system is suppressed. We talked about active, artificial, acquired immunity, and that occurs through vaccination or immunization. Immunizations introduce pathogens to the body in a controlled way, allowing the body to produce antibodies that prevent that future illness. We know that as nurses, we play an integral role in providing patient education regarding the importance of immunizations. And, with the current events right now, the viruses that are going around right now, it's important that as nurses, even as student nurses, that we are putting information out there that is factual, evidence-based, and doing our part to educate the public, to promote health in a deeper and further way. We know that decreased people with immunocompromised system, decreased immune responses, that puts the patient at increased risk for infection. So we know that measures, I talked earlier this week, that measures such as hand hygiene, washing those hands, the main thing is friction, running hot water, of course soap and hand sanitizer plays a part, but when we're doing hand hygiene, we have to make sure that we're not just getting the pads of our finger, we have to get all over. So, our fingernails, in between our fingers, all over the whole hand surface. Use that good friction under hot running water. And then of course, follow your facility guidelines for hand hygiene. But that's so important in minimizing the spread of viruses and bacteria. Strict adherence to standard precautions should always be implemented regardless of immune status. And that is to prevent healthcare associated infections. Sometimes just by people coming into the hospital, they're all of a sudden now susceptible to the bacteria and viruses that tend to stay in the hospital and the long-term care facilities, of course. So educating everyone, our patients, their family members, on how to limit the spread of viruses and bacteria, very, very important. We know that good nutrition, healthy lifestyle choices are important for a healthy immune system, getting good proper rest, getting the appropriate amount of sleep. Immunosuppression, where your immune system is not functioning like it should, that can actually be caused from treatments that treat things such as asthma, autoimmune disorders, and cancer. We know that with asthma, sometimes we treat it with steroids, and long-term steroids can suppress the immune system. So that's why we can actually cause immunosuppression through the medications that we're giving our patients. So it's very, very important that we teach those patients who are immunosuppressed, avoid large crowds. Right now we're saying, yesterday it was 50 groups of no more over than 50, or that was Monday. And then they announced right after that we should not be meeting in groups over 10. What does that mean? Avoid large crowded areas, especially if you're immunocompromised, if you're on medications that make your immune system suppressed. So that's very important. Also for the elderly, of course, the very young, and then those who have respiratory disorders. We teach them avoid large crowded areas, strict hand hygiene, and do our best to limit their exposure to possible antigens. So that was chapter 10, just talking basic about the immune and lymphatic systems. We know that the organs involved in the immune and lymphatic system include the bones. That's where inside the bone marrow, that's where our blood cells mature. We got the thymus, that's important. Our tonsils play a part in the immune and lymphatic system. And then of course our lymph nodes. Lymph nodes go all along our whole body. They follow our blood vessel tract, and they're constantly exchanging humors with the circulatory system and blood vessels. So what else? So lymph fluid, it's kind of clear usually. That definitely plays a part in the immune system. That's where antibodies are made. We know that with the immunoglobulins, we got IgG, IgE, IgM. Those are all important. IgD. Remember that IgG is the major antibody in primary and secondary immune responses that activates the complement system. It inactivates the antigen, foreign antigen, neutralizes toxins, crosses that placenta to provide immunity for newborns. IgA, that immunoglobulin, that's important for protecting mucous membranes on body surfaces. That provides immunity for newborns, prevents antigens on food from being absorbed. So the IgA, the location that is in your tears, in your saliva, in your mucus, in breast milk, important for mom and baby, in the GI, pulmonary, and then vaginal fluids. The other important immunoglobulin I wanted you to know was IgE, and that is what's responsible for allergic reactions. And remember, that only constitutes about 0.5% of your total immunoglobulins, but yet it plays such important part in people who have allergic reactions because it binds to mast cells, binds to basophils, causing that release of histamine. And remember, histamine is that important chemical that initiates that first response of inflammation to help protect the body. So I think that was it with chapter 10, but getting into this week's lecture, we're on chapter 11, and if we're having a different book, chapter 11 was Care of Patients with Immune and Lymphatic Disorders. So this is the lecture for Immune and Lymphatic Disorders. Some of the objectives we want to talk about the key differences between primary and acquired immune deficiency disorders. So let's look a little bit here on the PowerPoint. The primary immune deficiency disorders, we call that PIDD. That is the inherited genetic mutation that can be detected during infancy or childhood. And in our book, on page 217, box 11.1, some primary immune deficiency disorders are autoimmune lymphoproliferative syndrome, also known as ALPS. We got chronic granulomatosis disease, that's CGD. We got common variable immunodeficiency, CVID, and then we have severe combined immunodeficiency. Those are all examples of PIDD, primary immune deficiency disorders, things that people inherit through genetics that they're born with. And then we talk about acquired immune deficiency disorders. And with those are things that you can contract over your lifetime. So it can result from medications that cause immunosuppression. People who get organ transplants, they basically have to take immunosuppressive medications for the rest of their life. So that definitely quiets down the immune system so that you can accept, so that that organ can stay functioning within your body, this foreign organ that you receive from someone. Because the body, even though people have the same blood type, if you receive an organ transplant, chances are your body is going to want to attack it even if you have the same blood type. So you have to take immunosuppressive drugs for life, and that actually compromises your immune system, putting you at risk for increased infections. We know that acquired immune deficiency disorders, it can reduce the body's ability to produce white blood cells in the bone marrow. And if you're not producing white blood cells, your body's not going to be able to fight those infections that it comes in contact with. The most commonly known acquired immune deficiency disorder is AIDS. And that's caused by the human immunodeficiency virus, also known as HIV. Basically, over time, as HIV starts to progress in the body, it progresses to autoimmune deficiency syndrome, that's AIDS. And basically, usually people don't die necessarily from AIDS, they die from the opportunistic infections that we encounter in our daily lives. And when you have AIDS, your immune system is so depressed that it can't fight things like pneumonia, it can't fight the common cold, the flu. So you're definitely, people with advanced AIDS, they typically die from an opportunistic infection. So, but with a lot of the antiviral medications now, they're becoming a lot more cheaper, they're becoming a lot more readily available. So we're finding that HIV and AIDS isn't having that extreme impact as much as it used to when we first discovered it. We talk about autoimmune disorders. That's basically the body is hypersensitive to antigens from the external environment, and basically autoimmunity can be organ specific, such as in type 1 diabetes mellitus. where in which the body's basically attacking its own pancreatic cells. So that's autoimmune disorders where the body's attacking itself. Lupus, systemic lupus erythematosus, SLE, that is also an autoimmune disorder in which antibodies that are produced within the body assault your own healthy cells. One important key word that I want to talk about is iatrogenic. IATROGENIC, iatrogenic. And basically, that is how medical treatment induced immunosuppression. So like I said, drug-induced immunosuppression, often referred to as therapeutically induced immunosuppression, requires a delicate balance between the control of the body's immune response and the side effects. The ideal balance of therapeutic immunosuppressive drugs would inhibit the normal immune system response, defend against invasion from assorted pathogenic agents, and then control the occurrence of the unusual side effects such as stomach ulcers and tremors. With immunosuppressive drugs, one of the common side effects is stomach ulcers and tremors. So basically what we're doing here is trying to balance risk versus reward. So someone with a chronic disease, if they are suffering really bad, the medications that we give them to cause immunosuppression outweigh the risk of them getting an infection. So we look at benefit versus quality of life. And many times people with chronic illnesses, they need these medications to have some quality of life. However, these medications cause an iatrogenic response where these medications basically suppress the body's immune response. So that's important there. We look at some diagnostic tests and treatments of immune deficiencies. Some of those diagnostic tests that can help us diagnose autoimmune disorders, we see the CBC, the complete blood cell count with differential. We can look at the red blood cell count, look at the creatinine level, anti-nuclear antibodies. We can do bone marrow studies, serum protein electrophoresis, immunoelectrophoresis, T cell and B cell assays, and then enzyme-linked immunosorbent assays, also known as ELISA. So those are some examples of diagnostic tests that we can use to detect autoimmune disorders. Looking at one of our older care adult points, after the age of 70 years, there's a definite decline in the function of the immune system. Many of the blood-forming tissues in the bone marrow are replaced with fat lipids. B cell numbers usually remain the same, but T cell circulation is diminished. So remember what those T cells are. They mature in the thymus, and then they go into the tissue to help fight infection, foreign antigens within the tissue. So T cell circulation diminishes, but B cell numbers usually remain about the same. That's for older adults. Some of the things that we want to teach our patients who have compromised immunity, we definitely want to teach them about hand hygiene, performing it frequently, particularly before eating, after toileting, after petting an animal, after touching or shaking hands, and when returning home from shopping or doing errands. We also want to teach our compromised immunity patients to wash their armpits, groins, genitals, anal area at least twice a day with an antimicrobial soap. Dry those areas thoroughly. We want to teach them to obtain adequate rest that allows the body to function as well as possible. Take your temperature at least once a day. Assess for signs and symptoms of infection on a daily basis and report such signs immediately to the doctor. What are those signs? Typically fever, redness, some kind of congestion, mucus drainage, things like that. So not feeling well, malaise, body aches, nausea, vomiting, those all can be signs and symptoms of infection. We want to teach those patients with compromised immunity to take all prescribed medications as instructed, refrain from mingling in crowds, especially during flu season, avoid others who are displaying signs and symptoms of infection, avoid travel to areas with poor sanitation and inadequate healthcare facilities. We teach our patients to cook their foods very well, avoid eating raw, unwashed foods. Wash your dishes in the dishwasher with hot soapy water. Cutting surfaces and knives, areas that were used to prepare raw meat, we need to sanitize those afterwards. Do not dig in the soil or work with houseplants, and then use stress reduction techniques on a regular basis, such as yoga, tai chi, qigong, meditation, martial arts, things like that. So those are the teachings that we should be teaching our patients who have compromised immune disorders. Looking at HIV transmission, there was a lot of misconception at first when AIDS first came about how HIV was transferred, and people were afraid they'd get it through a hug, they'd get it through just looking at someone. But we know that the only mode of transmission is by exposure to HIV-infected blood, body fluids, or tissue. So that is how HIV can be spread. We know that any break in the skin or mucous membranes is an entry portal for HIV. The highest risk is people who have oral, vaginal, anal, unprotected sex, those who share needles and syringes with an HIV-infected person, and then maternal fetal exposure. That's also a way that HIV can be transmission. Pre-exposure prophylaxis. So for someone who thinks that they've been exposed to HIV and they're not sure, it's always to err on the side of caution. And for one thing, you know, if you're exposed to HIV or you get infected with it, it doesn't show up right away. It's gonna take a couple weeks, maybe some months to show up in the body. So what we do is someone who thinks that they were exposed to HIV, we give them pre-exposure prophylaxis, and we can do that with Truvada, emtricitabine, and then in combination with safer sex practices. So people who don't necessarily have HIV now, but their chance of getting it may be increased, we can treat them with pre-exposure prophylaxis. So that would include partners who have an HIV positive partner. We definitely want to, along with safer sex practices, educate them on these pre-exposure prophylaxis treatments that we can use to help protect the transmission of HIV. Looking at the diagnostic testing for HIV, that's used to monitor the immune status of an HIV positive patient. These tests are also used to diagnose that. And in our books, we got the rapid HIV antibody test that can use blood, saliva, or urine. Results are available within 10 to 20 minutes. If the rapid HIV antibody test is positive, it still must be confirmed by the Western blot test, the WB test. The WB test normally is negative. If we're testing for HIV and you test positive with the Western blot test, there can actually be a false positive that may be seen in the presence of maternal antibodies. But this Western blot test, it's the HIV antibody test that is used to confirm a positive HIV and ELISA. So if you have a positive rapid HIV test, if you have a positive ELISA, which is the enzyme-linked immunosorbent assay, it's a type of enzyme immunoassay to diagnose HIV, we still need to confirm it with the Western blot test. So the Western blot test is kind of the major confirmation that you have it. We first test you with the rapid HIV or the ELISA test. If you test positive for the rapid HIV antibody test or the enzyme-linked immunosorbent assay, then we say, okay, now you need to take the Western blot test. We need to confirm this. So that Western blot test is kind of the the gold standard for diagnosing HIV. Looking at the CD4 cell count. CD4 cell counts are very important because as HIV progresses to AIDS, it basically starts to bring down your CD4 levels. CD4 is very important for the immune system, helping fight infections. The normal value of the CD4 cell count is normally 500 to 1500 cells per unit of measurement. Values below 350 require prompt treatment, and values below 200, if accompanied by an opportunistic infection, confirms the diagnosis of AIDS. So remember, the diagnosis of positive HIV is different from a diagnosis of positive AIDS. People who are HIV positive do not always develop into being positive for AIDS. AIDS is like the super advanced form of HIV. So the way that we can confirm diagnosis of AIDS is CD4 count below 200, and then the presence of an opportunistic infection. And I talked earlier about opportunistic infections. Those are things that, infections that people are normally able to fight off with a healthy immune system. However, people with AIDS, their immune system cannot fight off these normal infections. So then they can actually die and get even sicker from getting these opportunistic infections. So confirmation of AIDS requires CD4 count below 200 plus the diagnosis of an opportunistic infection. To diagnose HIV, they have to have either a rapid HIV antibody test that's positive, an ELISA test that's positive, and then a Western blot test that's positive that can confirm the diagnosis of HIV. Looking at another autoimmune disorder, Crohn's. Crohn's is an autoimmune disorder of the intestines. That's an inflammatory bowel disease of autoimmune origin. Basically, the body is attacking itself. The area that's affected tends to be the ileum and the beginning of the large colon. Signs and symptoms include persistent diarrhea, rectal bleeding, fever, loss of appetite, bloody stool. So now our nursing interventions for these people with Crohn's disease, they have very important nutritional needs. They need a nutrient-rich diet with adequate calories, adequate protein, and healthy fats. Steroid medications are often prescribed with people with Crohn's, so that may increase their risk for osteoporosis. So sufficient calcium, sufficient vitamin D intake, magnesium, and vitamin K are all needed for bone health. And then we also know that with steroid medications, that can actually put the person at risk for opportunistic infections because it suppresses their immune system. So that's Crohn's. Looking at systemic lupus erythematosus, also known as SLE, that's an autoimmune disease with erythema, that's patchy, congestion of the capillaries of the skin with blood. The body produces abnormal antibodies that attack self cells instead of foreign invaders. So the signs and symptoms of that, one of the classic hallmarks of lupus is that butterfly rash that appears here. They have a wonderful picture in your book on page, I think it's 234 if you want to follow along in the book, that characteristic butterfly rash. We know that lupus affects multi-systems. It affects your skin, so your dermatologic manifestations include alopecia, that butterfly rash, discoid erythema, palmar erythema, mucosal ulcers. It affects the cardiopulmonary system. It affects the urinary system, affects our musculoskeletal system, also our central nervous system. It can actually cause stroke, seizures, peripheral neuropathy, psychoses, organic brain syndrome. It also affects the gastrointestinal system and then the reproductive system. So that's lupus. Lupus is systemic. It can affect all of our body systems. So signs and symptoms come and go. When we talk about waxes and wanes, the signs and symptoms come and go. There can be painful, swollen muscles and joints, extreme fatigue, unexplained fever, unusual loss of hair, sensitivity to sun, mouth ulcers, edema, swollen glands. All body systems can be affected. So what are some interventions that we should be teaching people with lupus? Well, looking at the signs and symptoms, when they got sensitivity to sun, we need to be teaching them, limit your time outdoors. If you are gonna go outdoors, use sunscreen, sunglasses, hats, protect your skin with clothing. There is no cure for lupus, and basically the target is symptom management. Control those flare-ups, minimize organ damage through non-steroidal anti-inflammatory drugs, or NSAIDs. We can use hydroxychloroquine, that's an anti-malarial drug, and then we can use glucocorticoids during flare-ups. So we know that with the intervention with this, using glucocorticoids, using steroids again, that can put them at risk for osteoporosis and also put them at risk for immunosuppression. So we have to teach them also to, like I said, those immunosuppression teachings, avoid large crowds, great hand hygiene, avoid people who are sick, things like that. So that is for lupus. Looking at lymphomas now, we're getting a little bit into our lymphomas. We got the Hodgkin lymphoma, we got non-Hodgkin's lymphoma. In Hodgkin's lymphoma, the Reed-Sternberg cells are present. If you want to get, so this is basically, lymphoma is a type of cancer of the lymphocytes. We know that with Hodgkin's lymphoma, genetics and the environment play a part in the development of this lymphatic cancer. Hodgkin lymphoma, if you had to choose one of these, you probably would want to get Hodgkin lymphoma because it's one of the more curable cancers when it's caught early. What else with Hodgkin's lymphoma? The ability to fight infection due to impaired defective B cells. Now, with non-Hodgkin's lymphoma, that's the more aggressive, the more unpredictable of the two lymphomas. Reed-Sternberg cells are not present. RS cells not present with non-Hodgkin's lymphoma. There's several types of NHL, non-Hodgkin's lymphoma. They're similar to Hodgkin's, but they're less predictable, more aggressive to spreading within other parts of the body. And we know that with cancer, when the cancer moves out of the area that it was contained in, it can spread to the body. And we know that the lymph nodes are connected through the whole body. So when you have cancers that are spreading through the lymph nodes, very easy for cancer to go systemic, to go to other places in the body. When you look at page 239, we see some of the signs and symptoms and treatment. Signs and symptoms of Hodgkin's and non-Hodgkin's lymphoma includes high fevers, chills, drenching night sweats, unexplained weight loss, cough, dyspnea, chest pain, nausea, vomiting, constipation. Hepatomegaly, splenomegaly can occur. The lymph nodes tend to be closer to the skin, so they're more easily palpated. They may have, more than likely, they're gonna have lymph nodes that are swollen. Laboratory tests may show elevated liver enzymes. So like I said, to diagnose this, they look at the RS cells, the Reed-Sternberg cells. They also can use CTs, MRIs, PETs, and ultrasounds to determine the extent of tissue that's involved in this cancer. They do biopsies of various body tissues, fine needle aspiration. They can excise a biopsy where the entire node may be removed. Medical surgical teaching for patients who get a biopsy or a fine needle aspiration. We definitely want to be looking at that site, teaching them if there's abnormal bleeding, watching for signs of infection. We want them to report that to us. Surgery may be attempted if the tumor is localized or as palliative care. Some vaccines for these diseases are currently in clinical trials. So nursing care is directed towards supporting the patient through the diagnostic process, observing for and treating the side effects of radiation and chemotherapy. When bone marrow or stem cell transplants are performed, nursing care and patient education must focus on the prevention of infection and other complications. So, some of the common problems for people with non-Hodgkin's lymphoma include potential for infection due to neutropenia, risk for hemorrhage due to, from thrombocytopenia, fatigue, nutritional deficit. So some of our nursing outcomes will be patient will not experience infection, patient will not experience hemorrhage, fatigue will lessen after 6 weeks of treatment, patient will gain back the weight that they lost. What else is important here? I think we got one more slide here. Fibromyalgia. Fibromyalgia in the 1970s was identified as a condition of chronic systemic pain. Basically, fibromyalgia was unexplained pain in the body, basically pain that could not be found to have a cause or a source. Patients typically have hyperalgesia, which is a heightened response to painful stimuli. They may have allodynia, which is pain response to non-painful stimuli. So basically, sometimes if you're about to touch this patient, even before you touch them, they may be saying ow already in anticipation of the pain. So we have to be aware that people with fibromyalgia, they can have chronic muscle pain, spasms or tightness. They may have stiffness upon waking or staying in one position for too long, moderate to severe fatigue, decreased energy levels, reduced exercise tolerance. They may get tension or migraine headaches, jaw, facial tenderness, insomnia, sensitivity to odors, noise, bright lights, medications, foods, and cold, a sensation of swelling. So it's almost like there's no specific diagnostic test that can confirm the diagnosis of fibromyalgia. It's more diagnosed on the symptoms. So what can we do? Nursing responsibilities include taking a detailed history of the symptoms, measures that the patient has used that were either effective or ineffective at relieving the pain. And then the interventions should focus on helping the patient manage their fatigue, pain, activity intolerance, sleep disruption, and stress. Families should be included in this education process. So like I said, fibromyalgia, chronic unexplainable systemic pain symptoms, possibly due to an alteration in the way that the brain perceives pain. It can be triggered by stressors such as infection, trauma, family history, autoimmune disease. The treatment is based on symptomatology, and can include light exercise, massage therapy, guided imagery, dietary changes, maybe a mental health care provider, medications such as pregabalin, also known as Lyrica, duloxetine, also known as Cymbalta. That's a low-dose antidepressant like tricyclic. SSRIs and benzodiazepines can be effective at reducing the amount of pain and symptoms that patients with fibromyalgia have. Nursing assessments, primary and allergic conditions. What are we doing to assess people with allergic conditions? We look at their family history, we look at their food intolerances, we ask them about digestion issues they may have, unusual reactions to insect bites, unusual reactions to drugs or medications, any respiratory problems. We want to definitely monitor their skin and watch for itching, burning, scaling, irritations, inflammations, rashes, eyes, ears, nose, and throat. For people with allergies, we're looking for redness, congestion, itching, sneezing. We want these patients with allergies to keep a diary of the makeup they use, the foods they eat, toiletries such as lotion, soap, shampoo, household cleaners used. This is for people who have allergies and they don't know why they have an allergy. So for people who don't know what is triggering their allergies, those are the ones that we encourage to keep a diary so that we can start to connect some dots and link some things as to, okay, we know it's not this that's making you allergic, we know it's not this, but possibly it's this. So that's important for that. So, all right, finishing up here. So that was the lecture for patients with immune and lymphatic disorders. So next week we'll be going, I don't know if we're gonna have school or not next week. Stay up to date with your Blackboard. Check your Blackboard once a day. Check your Bryant and Stratton email once a day. Things can change on a day-to-day basis, so very important. Look at those key points at the end of chapter 11, page 249. I want you doing those NCLEX review questions on page 250. Do 1 through 10. Look at those critical thinking questions, the 2 scenarios that are there on page 251. And then I'll be in contact with you throughout the week. So go over chapter 11, and then next week, if we're still not in class, I'll post a video for the lecture on chapter 8, which is cancer. So, okay, we'll see you soon. Study